our patient population, as far as all the people can correct me, sometimes have unrealistic expectations, and they want everything done. Sometimes with not a lot of participation on their part. I think this is a big issue. But having said that, I think at the end of the day, they are facing a very difficult problem, and it's not fair to sometimes ask them just to do more and more. Dr. Nasser.
Thank you. Really, we faced in my institute, we had we asked the patient to reduce their weight for two things, as you said: to reduce the weight, to reduce the liver size, and especially in huge patients. And we really find difference between patients who keep or they can reduce their weight with their liver size, and to be compliant in the future when they face a lot of problems to keep their weight till surgery, till the time of the surgery, they be more restricted to diet and more compliant. And both of them, really, we understand both of them, both points. Thank you.
Let's before you tell us who agrees with the transaction you're doing. Like, you think it's good, too much, too little? Can you comment first when they do the first transaction? Any comments about it?
I was not concentrating on the position now. Maybe we will see it again. I'll comment. But for the diet, I would say 90% of the people coming to our clinic, they already have tried all protocols. So from that visit, you will be able to judge how much they are reliable, how much they have tried hard to lose weight. And I don't think the diet will be
something preventing this.
Kelvin, can you hear us?
Yeah, I can hear you now.
Oh, great. So we have a couple of questions for you. Maybe you can answer for us. We noticed that it was very difficult to get to the blood cruise and take the top short gastrics. What are the things you can do when you're having trouble and you cannot get to the top of the left cruise or the short gastrics? Make it easy.
Hold on 1 second, Grasper. So the question is, if you're having trouble getting to the top, the short gastrics, you can do what Dr. Bashir did here, and see the subsecond right there. There. Okay.
One important is using purple in this with diabetic patients. I don't know how long the diabetes. The stomach is thick in diabetic patients, and in the antrum here, definitely there might be serosal care by applying purple. I will use black, though I need the 15 trocars, but black might be the best. I think in terms of the virus, I think that is fair, but we don't see the virus now. I think it's fair as size-wise.
Stay away from this angle, just a little bit more. Yeah, I think using black markers here is okay. But I think in this part of the study, it's a judgment call, right? How it feels. There's a certain people. I'd rather cross the speaker line than leave it. Okay. Is that good? Yeah. I just err on make it wider than, you know what I mean? It's so narrow here. The bougie we couldn't negotiate the bougie, so the bougie is, we're going to do the first line without the bougie. Okay. So let's see, how far away. Okay.
Do you think you're how close are you to the pylorus?
Just like so. We'll show you guys in a second here.
Can I ask a question?
I still don't like it. I don't like it. Because the angle is wrong. Let's try to get the bougie down. That's not how to get. So we're not liking that angle at all. So we're going to reapproach it from a different angle, maybe put the bougie across because it's just
not under the
it's
cube.
not quite right.
Cube.
Okay, so yeah, the suggestion is using a black is a good one.
With the cube.
And how we pick up the highest that we talked about a little bit here. Go ahead, Q.
Very ratio.
Kelvin, what size is Fuji and any consideration to use an endoscope for getting pylorus?
Very, no.
Okay, you can see the pylorus pretty well here, but the problem is the bougie is a little stiff to kind of negotiate and go through the pylorus. You can use an endoscope as well, but you know, this is a 40 French bougie, so the endoscope is a little bit smaller. And that's an option as well. So they also recommended, no, we can't get the bougie in there, we can put an endoscope down and guide it. Do we have it?
We do.
Yeah.
So I think this is, I'm trying not to try it, not so much to try. I think this is okay, right?
Yeah, that's okay. If you do the angle right, it looks okay to me.
And if it is difficult to pass to the virus, just leave it there, apply the staplers on the bougie, beside the bougie while it's in the diagram. You don't need to go.
I think that the most important thing in cases like this is to take your time. This is another case you should be worried about time and trying to do it quickly. And obviously, a very difficult case. So I think any time spent to get things organized is time well spent.
The angle? The angle?
Anything else?
Oh, wait.
You want to
Case
use
like
that
this.
Yeah. Right? Yep.
It can be very difficult to actually identify where the pylorus is even. And I think it's important to put the bougie down because oftentimes that can help you identify exactly where the pylorus is. And I think Mary made a good point at the beginning. Too close to the pylorus, you can affect the pyloric function.
Is that okay? Okay.
Yeah. Yeah, and I think if there's any question, you want to err on the side of being a little bit larger than tighter, especially in this area here. Second, we'll know if we should have put a black one. Get a better picture, huh?
Yep.
We'll get a little better picture.
Anybody in the audience needs a buttress material, either very straight or C5. Anybody?
Except the rest.
Can we have a mic in the audience? How many people in the audience would make the first fire tighter than what they had, closer to the bougie? Anybody in the audience would make it closer to the bougie? Anybody would make it further away from the bougie?
Yeah. That's all right, you're getting irritated anyway.
Excuse me. May I have a question, please?
Yes.
do you have any idea, most of the cases, the first statement usually we have bleeding. Either we use the purple or even the black. Do you have a suggestion with that? Why we got bleeding at the beginning, first statement, and we don't get in the further statements?
Kelvin, there's a question from the audience. They say that the question is, why is it more often that you have bleeding from the first statement firing and not from the rest?
Oh, I think you get bleeding from the first firing because you tend to oversize the stapler. You're trying to use a bigger stapler, and looking back, we should have used the black on this one, but the stomach is really a lot thicker there, so we generally use a larger cartridge. It's kind of a judgment call, because it's not just what it seems, but also what the tissue compresses to be. So, and of course, if you use reinforcement, you don't seem to see that. So, what's the consensus? Reinforcement or non-reinforcement?
Yes.
Okay.
I have a question for you. Do you think in such cases, intragastric balloon, reinforcing balloon,
Research.
do you have a certain number of BMI that you will recommend insertion of intragastric balloon?
Okay. Kelvin and Ahmed, there was a question. Is there any certain BMI where you recommend the patient gets an intragastric balloon before they undergo their bariatric surgery? First question. Second question, what is your stand on preoperative diet? Did this patient go through preoperative diet?
Well, let me ask. I'll answer from my standpoint, and then I'll ask Dr. Bashir. So, Dr. Bashir, the question is, do you think that this patient could have used intragastric balloon or a special diet preoperatively to help increase the weight of the liver size? Or do you do that routinely?
Myself, I don't do that routinely except for high-risk non-compliant patients, just to make sure that they are compliant.
So only high-risk non-compliant patients for Dr. Bashir.
Basically, I actually keep them in the hospital for 2 weeks if I can.
So is my microphone's picking up Dr. Bashir, is that right? I don't have to answer for him?
You have to tell us what would you do if the patient gains weight, because we have the audience here a strong opinion that you should try preoperative diet and you should not operate if they gain weight.
Okay, hold on a second. We're trying to get this stable this way.
Okay.
Okay, so my personal opinion is that it's always good if the patient loses weight right before surgery. Although I don't generally make it a mandatory thing for them unless they're, 900 pounds. I really think that it's dangerous, And I'll go through so much as I'll admit them to the hospital and get them to lose weight as an inpatient if they're observed allowed. I have no experience with the intragastric balloon. Maybe Dr. Netta can tell us, because from what I understand, the stomach gets pretty effaced when you put the balloon in, and the stomach really is not the normal stomach, and I don't know if that's a high risk or not. As far as gaining weight, that's a tip-off of the problem. So either the patient is going to be non-compliant, or the patient is going to, we need to be right back here.
But what do you do with that tip?
Patient is not going to be non-compliant.
No surgery for you?
So, yeah, so if we see a patient pre-op a week before surgery, if they gain a lot of weight, then we tell them no surgery. And we reevaluate what's going on. Are they binging? Are they you know, just not ready psychologically to handle this, because usually patients are they're not on a trajectory to gain weight, they're just in a steady state. So anytime I see acute weight gain right before an operation, and I'm not talking 5 or 10 pounds, I'm talking about, you know, 40, 50, 60 pounds of weight gain in 2 months prior to surgery, there's something obviously not right about that. So those are the patients we'll move off and I say, listen, we got to figure out what's wrong with you. And then we'll see them back until they're ready. And that was good. So, you know, anything that'll make the surgeon's job easier, I think, is worthwhile. Whether that's mandatory weight loss. You know, the problem I have with mandatory weight loss before an operation is there's a bit of vessel back there. You know, if you make it mandatory weight loss and you don't do surgery until you lose weight, to me that's kind of mean. Because they come to you because they can't lose weight in the first place, and then you're making them lose 10, 20% of the weight. It just doesn't make sense. And that's different than acute weight gain after, you know, right before an operation. The strategy is good, of course, and then judgment call, right? So you lay the patient down, you look at their sternal belly angle, at this 90 degrees, you're in big trouble, it doesn't matter what their BMI is. And then that patient needs to lose weight pre-operatively. However, if the patient got a BMI of 70 and they lay out flat and it's well proportioned, that patient's not going to be a problem for you. So I think there's no hard and fast rule of what the deal you get prior to surgery that you use.
So, are you guys going to try and transect the center completely before you take down all the gastric rejection?
Okay, so that's one of the, so taking down the transecting the stomach, taking out short gastrics from medial to lateral is one trick you can use on difficult patients and maybe safer. In this case, I think we identify and get the crew sound, it would certainly be possible to do. I think we should just look at the crew. I think we almost got the retractor every night there and everything.
Switch handles?
Yeah. Just hold that down to the low and then we'll get up the left cruise and then I think it might be better to transit the stomach and then take a quick gas from the other side. Come in a little bit. Either way, it's always better to identify the left cruise, I think. So we'll take that stuff down. And then no matter what, you can do it. And personally, I like taking off the fat pad off the angle of hips, because that helps identify things a little bit better, but I know some people believe that you vascularize that area and leads to leaks. I don't think so. But there's a big difference between what I think and what's true. You almost got this. Take that down. And then take that back and use it as a
That's great exposure.
bucket spray. So this is the irony, you know, this is kind of a difficult